Good morning, ladies and gentlemen. I would like to welcome our colleagues from Edinburgh. I will not hope to be able to cover atrial fibrillation in 20 minutes, but I will try to make some salient points. Atrial fibrillation, as we all know, is the grandfather of all arrhythmias. I will try to explain some of the guidelines for anticoagulation, to try and discriminate patients requiring restoration of sinus rhythm versus rate control alone, and determine when patients should be evaluated for curative therapy in the form of ablation. Atrial fibrillation is growing. We are becoming an aging population generally across the globe. Atrial fibrillation prevalence and incidence is increasing, and these are the projected figures. These are the projected figures in the United States, and as you can see, the numbers will probably more than double by the year 2050. It is age, it is a disease of all people, and the prevalence of atrial fibrillation in the 70 to 80 age group is in the region of 5%, and in above 80 it is about 10%. The costs to the health system are immense. 35% of arrhythmia hospitalizations are due to atrial fibrillation. Average hospital stays 5 days. That does not include the costs of cardioversions, drugs, and the strokes that are caused by atrial fibrillation, which are disabling. Atrial fibrillation, as per guidelines, when first detected, can be self-terminating, a first episode. It can either be paroxysmal atrial fibrillation, i.e. self-terminating atrial fibrillation, or it can be persistent, not self-terminating. It can go on to become permanent, and there is an interchange between all of these. Your aim is for your patients to be in sinus rhythm whenever you can. The minimum diagnostic workup required for these patients: a history, an ECG, to recognize some of the particular excitation, which in the presence of atrial fibrillation can be very dangerous. The routine lab works, thyroid functions, additional testing, a treadmill, a halter. EP is important as well in some patients because atrial fibrillation can be triggered by specific forms of disease. What are the options? Rate control, pharmacology, from calcium channel blockers, beta blockers, digitalis, non-pharmacologic rate control, ablation and pacing. Maintenance of sinus rhythm can either be pharmacologic or non-pharmacologic. Pharmacologic maintenance of sinus rhythm, as we know, class 1A, 1C, class 3 drugs like amiodarone or beta blockers. Non-pharmacologic maintenance of sinus rhythm, which is growing in the form of RF ablation, cryoablation, surgical mace procedures, and pacing. Probably nobody does that anymore. Prevention, pharmacologic prevention. We must all remember that atrial fibrillation patients do benefit from ACE inhibition or angiotensin receptor blockers. They do help in reducing the recurrence of atrial fibrillation. Stroke prevention. 30% of strokes are caused by atrial fibrillation. It's a disabling disease. We must all pay attention to this. And strokes can be caused by symptomatic or asymptomatic atrial fibrillation. Sometimes people do not feel atrial fibrillation. we need to prevent it and treat it. Pharmacology therapy in the form of oral anticoagulation, thrombin inhibitors, this is the state of the art nowadays, and aspirin, non-pharmacologic therapy in the form of left atrial appendage closure devices. So, when you have AF, you need to have antithrombotic therapy. And then you need to decide which arm do you go. Do you go for rhythm control, i.e. aim for sinus rhythm, or go for rate control, to control the rate alone and leave them in atrial fibrillation. Now, no AF talk can be complete without this trial. A firm trial, I will not go into the details, but that is really an eye-opener for all of us. It was published in 2002 in the New England Journal of Medicine, and it showed, it's a solid trial, and it showed that rate control and rhythm control, mortality-wise, there was little difference. In fact, there was a trend towards a better survival, less mortality, with rate control alone. Now, what are the implications? It's an acceptable, rate control is an acceptable primary therapy in selected patients. Continuous anticoagulation seems warranted in all patients with risk factors for stroke, even asymptomatic recurrences. AF per se, as a rhythm, it's really life-threatening, but its consequences are. So, in symptomatic patients, what you aim at is reduce the frequency of recurrences, reduce the duration of recurrences, and reduce their severity, minimize the risk of tachycardia and induced cardiomyopathy. This is an area that we are only becoming aware of. 30% of LV dysfunction that we see in atrial fibrillation patients is a direct result of atrial fibrillation. So if you treat atrial fibrillation, they do improve. The ventricle will improve. So safety is primary concern. Safety, saving myocardium and saving the brain. Many complex scores have been devised to decide which patients need anticoagulation. And this is probably the most comprehensive. It's quite straightforward. You calculate points, and that decides, you decide how, if your patient needs anticoagulation. What's the problem with rate control? Increased rates mean no symptoms, greater hemodynamic impact, and as we mentioned, tachycardia-induced cardiomyopathy. The goal with paroxysmal AF, you need to control the symptoms of the recurrence. In chronic AF, you aim for a heart rate of less than 80 to 90 beats. Drug therapy, a combination probably with digoxin. Digoxin is very good at controlling resting heart rates, especially in patients with congestive heart failure. Beta blockers and calcium channel blockers control resting and exercise heart rates. So the best therapy is a combination of both beta blockers and digoxin. Even with the best rate control, sometimes pacing support will be required to be able to control their symptoms. If you choose to go to rate control plus anticoagulation, this is usually preferred in minimal symptoms or no symptoms, longer AF history, more structural heart disease, toxicity risk from antiarrhythmic drugs, older age, and greater risk of proarrhythmia in some selected groups. So for these patients, you aim for rate control and anticoagulation. When is rhythm control preferred? If there are greater symptoms, if patients are symptomatic despite rate control. In younger age patients, when they have minimal or no structural heart disease, and when the option of anti-arrhythmic drugs is class 1C, then we probably should be aiming for arrhythmic control. In anticoagulation, if you go for rate control, it is indefinite. There is no, it's for life. Now, for cardioversion, how successful are we? We are usually successful acutely in the initial phase, but our success rates do degenerate. So in the long term, the best predictor of AF recurrence is the duration of atrial fibrillation. So if your patient, if you've got the patients within the first 3 months, this is your window of opportunity to be able to do something about it effectively. So the success rate in the long term is about 70 to 80%. The duration is less than 3 months. If the duration is more than 12 months, then you're talking about 20-25% success rate in maintaining science. Warfarin is not without a price. Several algorithms have been devised to predict bleeding risk from warfarin. This is probably the best available. The usual clinical characteristics that increase the risk of bleeding, hypertension, abnormal liver or renal function, previous stroke, bleeding tendency, labile INR, elderly patients, and concomitant drugs or alcohol. We have to mention that from the inhibitors. We are lucky now that we can do away with warfarin. It is class 1 indication in the guidelines, and oral active direct thrombin inhibitors are an alternative, but we must remember they are not to be used with atrial fibrillation that caused by valvular heart disease. So far, it is non-valvular heart disease, and it's not to be used in patients with artificial heart valves. Do we have alternative therapy to atrial fibrillation? Yes, we do. Warfarin, now we can have left atrial appendage closure devices, and several trials have demonstrated their effectiveness at preventing stroke. If we have no problems with their rate control with drugs, we can go to AV node ablation and pacemaker, i.e. cut off all conduction from the atrial to the ventricle and pace the ventricle. This was very popular at some stage, but nowadays not many people will do this because now we have the better option of ablation of atrial fibrillation. Ablation really came when we became aware of how AF starts. AF, there are foci in the pulmonary vein, sometimes in the SBC. They trigger atrial fibrillation, and then you maintain atrial fibrillation by these reentrant circuits, numerous reentrant circuits in the atrium. So it is triggered by a focus and maintained by reentrant circuits. 95% of triggers for AF are in the pulmonary veins, left upper superior, left upper, left lower, right upper, right lower, sometimes in the SBC, sometimes in the SBC, in the IBC or the coronary response. What we do, ablation, we record from within the pulmonary vein, and then we ablate, aiming to isolate the pulmonary veins. So if you isolate the pulmonary veins, the trigger will not reach the atrium. So that is what you aim at. And there are several ways and several methods. In long, laborious procedures, you aim to make a line to separate both the left veins, right veins. Some people do lines here and there to increase the success of the ablation procedure. ablation, you put a balloon in the pulmonary vein and you freeze it down to -50, -60, and that will create a lesion all the way around, isolating that vein from the atrium. Success rates I will mention in a minute. So, what is our best current state curative for asthma? At 1 year, after the first procedure, our success rate is probably 60 to 70%, and 80% after a second procedure. So that is very decent, but it's not without a price. Serious complications are there, and probably the most serious are CVAs and esophageal left atrial fistulas, which are quite fatal. I must stress the point that our best success rate with drugs for atrial fibrillation is in the region of 50%. And probably to me that is high. It's probably less than that. For ablation, our best success rates are around 80%. But that is not without the price we just mentioned. Who's good for a curative AF procedure? Symptomatic, frequent AF patients, minimal or no structural heart disease, decent ejection fraction, smaller left atrial size because if the atrium is huge, you'll just be swimming in that atrium and your success rate is low, and no rheumatic heart disease, specifically no mitral stenosis. In younger patients, and when there is no left atrial thrombus or history of CVA, and medically refractory or intolerant to drug therapy. So now, ablation is the second line therapy. If you fail with drugs, ablation is the second line therapy. Watchman, several devices are this is for closure of the left atrial appendage. This is the challenge we face, and we really have a hard time. It is a very difficult disease to actually conquer. Thank you very much.
Dr. Yahya, do you intend to convert AF to sinus rhythm before, during, and after mitral replacement, surgically, pharmacologically, or non-pharmacologically? Or you give anticoagulants and let it be?
In mitral valve disease, specifically or especially mitral valve stenosis, the atrium is usually big, and these patients are usually destined to atrial fibrillation. They will usually have chronic atrial fibrillation. So, and they will usually need anticoagulation. So probably the best policy for these patients is rate control, to control the rate. They are anticoagulated anyway. But in some patients, if the AF is recent, if the atrium is a reasonable size, and if they are symptomatic or difficult to control with their atrial fibrillation, then I think rhythm control is a reasonable target. Although it will be difficult, and it has been known radiofrequency ablation and cryoablation can be done for these patients as a curative therapy. So it really is an individual case by case for each individual patient. But the majority are destined to AF, and rate control is the way to go.
Thank you very much for the nice talks. سؤالين صغار يا باشا حكيتها يعني. First one is coronary angiogram indicated in all patients with heart failure or not? This is first question. And second is, if you allow me, Basha, we're basically all internists, so we come almost about a suspicion of heart failure on daily basis. So when to refer? Is there anything that we can do before referring to you as a cardiologist?
First question, is coronary angiography indicated?
Is it indicated in all patients whom you suspect heart failure or diagnose?
I think it is at least to clarify the anatomy and see the coronary. Because there is any coronary disease, and sometimes the patient cannot differentiate between chest pain and dyspnea. There is evidence of vibrant myocardium and angina. As I mentioned earlier, you operate. Yes. I personally try to evaluate coronary angiography or coronary anatomy in most patients. It's straightforward, you know. There's no hope, no shoot, but most of the time, was there a question?
When we suspect, as internists, when we suspect a case of heart failure, should we refer everyone to a cardiologist, or we can do as internists something?
No, I don't think. I mean, as I said in my talk, the best primary prevention of heart failure is to treat hypertension properly and diabetes and coronary disease. You know, hypertension and ischemic heart is more than 60% contribute to heart failure. Both heart failure with zero ejection fraction or reduced hypertension should be treated very properly. Control hypertension and we delay the progression from stage A to B to C, that would be a great achievement. No, I don't think we need to refer every case of heart failure, of course. Proper medical treatment can do that.
Professor Lee, thank you very much indeed for your talk. I have just only one question, because TAVI is not progressing very much in Jordan because of the cost, and maybe we are still waiting to see more and more results. We are very much concerned about the complications of the procedure and the evolving technologies. Now companies are producing more and more valves. Do you have a certain preference for certain valve that's coming?
At the moment, the TAVI valves, at the moment, there are really just two that are available. The Edwards valve and the core valve. However, there's been an explosion in investment by companies to produce more and more of these valves. And also, the tubes that put them in, the catheters, are getting smaller and smaller. So eventually, it won't require such a big hole in the groin leading to complication. Also, people have been working very carefully on the ability to try and decrease the risk of stroke with this procedure. Because in the big trial comparing TAVI with surgery actually did better in terms of had less likely to have a stroke with a surgical aortic valve replacement than you were with the TAVI. So in some ways, Scotland tried to do the same as Jordan in the fact that we held off for as long as possible to see what was going on. I think that with all these things commercially, when more companies bring out more valves, the cost will decrease. The funding model in Germany has meant that Germany performs almost as many TAVIs as they do surgical aortic valve replacements. And it's been rather uncontrolled in Germany. So there is some concern now about some of the TAVIs that have been performed in a 60-year-old person. They're coming back with the TAVI failing after 5 years. So in some ways in Jordan, I can see that it's frustrating that if you don't get it started. On the other hand, more information is coming out about these things the whole time, which will guide you actually more about it.
Do you give these patients aortic stenosis, statins, irrespective of, as you said, heterogeneous, cerebral forces? Do you think statins will decrease concentration? Do you think there is statins?
Personally, I do. But there was one big trial, I think.
Does not meet the primary concept.
Exactly. But personally, I do. And also, I think it's important, as you were saying, for heart failure, to make sure that although the patient has aortic stenosis, you're not mistreating the coronary disease, the hypertension, and other risk factors.
I agree.
Thank you, Dr. Bayer. I'll stay with Dr. Bayer.
I have two small questions. On the first case, you presented the attorney who died.
Yes.
I did not see serial troponins being done versus what we do in the US. When we are presented with such vague chest pain and you don't know really what's going on, we do admit the patient for observation for at least 24 hours, and we do Q4 to Q12 troponin levels. What's your standard of care there?
Very good question. So just on the patient I presented, I didn't present it very well because he was kept in hospital and had a 12-hour troponin which was negative. At the moment, we have to keep patients for 12 hours. But in terms of cost, it would be an awful lot better if you could do a blood test as soon as someone comes into your ED or your accident emergency department and say whether this was cardiac chest pain or not. And one of the drivers for getting this very sensitive troponin is the possibility that it might be that you could do a blood test after an hour and send someone home and not admit them to hospital, which is the expensive thing. At the moment, we are admitting people doing a 12-hour troponin. That gentleman's troponin was negative, but yeah, I would agree that that's the British standard of care.
Just a little part of this, do you look at only going up? Also, you're looking at going down, because some people will come with their peak troponin and their cardiac mass is not high enough, and then starts to drop. So you look backward and think, oh, maybe he was in MI at that point. So usually, do you tend to look at the upward rise or both?
Both. And also sometimes patients who I was talking about come into hospital and they have a positive troponin, which has nothing to do with their heart. Those patients normally see the troponin might stay at the same level after 12 hours or so it's useful in that respect as well.
Sure, actually, we just had the same case, but luckily the guy did not die because actually it was ordered, but the machine did not pass and the test was not done. But we caught that person in the last minute. The other last question, what do you think of induction of moderate hypothermia for TAVI and any other aortic valve and aortic aneurysm procedures? Because in Boston and some other centers, now they started to address actually putting the patient in the what we call prior death stage or pre-death stage.
I'm personally not aware of that, but we've been involved in some trials of patients who've had out-of-hospital cardiac arrest, and therapeutic hypothermia for them to prevent brain injury is very important. So I would imagine that it may be beneficial, but the amount of cerebral stunning might be a lot less that you should get from a TAVI than from a cardiac arrest. That'd be helpful.
Thank you so much.
They are using hospital setting there.
Yes.
I want to ask, is there a role for coronary artery CT and
Not in our ERs. However, my father-in-law lives in Hong Kong, and he was admitted to hospital with some chest pain, and their exclusion test was a CT coronary angiogram with CTPA, and he just returned from a flight to Australia and was picked up with a pulmonary embolism, although they suspected coronary disease. So it is being used in other parts of the world, but for us, we're not using it to exclude coronary disease.
Thank you, Dr. Yusuf, for your good lecture. There's a new study published in San Francisco Hospital revealed that sport is reduce the mortality between patients with heart failure with about 10% and improve about 40% of patients with heart failure. They said that sport is very important for treatment of heart failure. Do you agree with this study? Thank you.
I'm not aware of this, but we encourage our patients to do exercise like that. It helps heart failure. Do you have anything on that?
Just that we have a cardiac rehab service, and they keep telling us that And there's evidence for benefit after heart attack is rehabilitation and exercise, so it could be extrapolated to heart failure.
At least when he exercises, he is compliant with his treatment. He reduces his weight. He doesn't add weight. I mean, it helps definitely.
Thank you for your presentations. My question for Dr. Yahya about ACE inhibitors and ARBs. Is it mandatory to use in all patients, or there is selected groups to choose?
I think in patients, definitely with hypertension, patients with enlarged atriums, and in patients who have evidence of left ventricular hypertrophy, ACE inhibition is important. It does reduce the recurrence of atrial fibrillation. And interestingly, statins have also been added to this. So statins, there is some evidence that they do decrease the recurrence of AFs. But if patients have recurrent AF and their blood pressure tolerates it, yes, I do keep them on ACE inhibition.
Thank you all. Thank you very much indeed. One very short question, last question. Now we are hearing about new modality of treatment of acute heart failure. It's relaxed. Maybe it's not approved yet by the FDA, but maybe it's promising. Can you tell us a little bit about that?
I know it is. It's coming. I didn't touch on it heart failure because I was constantly on congestive heart failure. Vaccine, it's coming up. They're telling me that next year it will be approved. I don't know whether it's very, very promising or not. We have an idea about the vaccine. Novartis. We're not promoting Novartis now.
Yeah, they claim it's a breakthrough in the treatment of heart failure for over the past 2 decades now.
It would be very important because it's a very common presentation, but I'm not aware.
All right, thank you very much indeed. We'll have a break now and we'll be coming back by 11. Sorry? Thank you, sir. Thank you very much indeed. Sorry, I'm sorry.
لفوا دكتور لفوا كمان واحدة؟ لا لا Thank you very much. باشا يوسف عمي أنا أستاذي حبيبي الله يسلمك. لا يحيى حبيبي الله يسلمك. وين مكتوب على يوسف؟ ذبحتوني. انت كان لازم تتصور معها. ثانك يو فيري ماتش. دكتور صورة جماعية كلكم. يلا صورة جماعية.